Hello, exchangers of gas. Welcome to the Gas Exchange podcast, where we talk about respiratory critical care. The information provided in this podcast is for educational and informational purposes only and is not intended as medical advice. This podcast is part of our efforts at Inspire Respiratory Critical Care, where we provide expert panel discussions, pearls, virtual classroom lectures, and other initiatives. You can find our podcast on YouTube, Spotify, and Apple Podcasts. On our website, inspire-rt.com, you can find links to our past recordings and many other resources. My name is Keith Lamb, and I'm the host. I'd like to welcome my very special guest today, Dr. Bruce Rubin. Bruce is a highly respected clinician, a highly regarded researcher and expert in many, many things. Dr. Rubin is a great friend of our profession, and I've known him for very many years. Welcome, sir. Can you tell us a little bit about yourself?
Certainly, it's good to talk with you, my old friend Keith, and to I guess shoot the spit. I am, I am semi-retired now, but by way of background, I trained as a physician I'm Canadian, trained as a physician at Tulane in New Orleans, then received a Rhodes Scholarship to Oxford, where I finished my graduate work in biomedical engineering in the pediatric bioengineering unit. This was the 70s, so I was developing some of the first dedicated neonatal ventilators as opposed to scaled down versions of adult ventilators. Then returned to Canada to do my respirology fellowship, which is what they call pulmonology north of the border. And have been practicing for a number of years as both an engineer and a physician. My interest has been largely fluid dynamics or fluid flow. And in the airway, that's mucus clearance from the airway and aerosol delivery to the airway. And as such, my natural partners are respiratory therapists. So one of my proudest moments was when the ARC made me an honorary respiratory therapist. And the only caveat was I was still not allowed to touch the ventilator.
You're in good company there. Well, I'd like to welcome you again, Bruce. Really appreciate you coming on today. Tell us something that not everybody knows about you. So I was going to mention that you're a Rhodes Scholar, but you went ahead and got that out of the way. Tell us something that you do when you're not saving lives.
I'll tell you a couple. I was a street performer, a busker in Canada and in Britain. And my thing primarily was playing blues harmonica with my nose. And I'm one of the top nose harmonicists in the world, which is a very small pool to swim in. And one of my fellow scholars, Harry Prince, and I published a small book called Busker's Guide to this London Underground, published by not the Oxford University Press. But the other thing I've done over the years is I'm a magician, member of the International Brotherhood of Magicians, and hold the Order of Merlin in that group. And in that area, I've taught bedside magic to pediatricians in more than 40 countries, and have actually enjoyed publishing some of my own ideas in the magic literature. So I guess those are two oddball things that have kept me occupied. I guess the other thing is I'm a professor in Lviv, Western Ukraine, and I work there each year as a volunteer helping out at the Children's Hospital.
Wow, that's all exceedingly impressive. And most of that I knew, but some of it I did not. And so it's great to hear. So you are an expert in many things in medicine. One of the things that I talk to you about quite often is mucus clearance and mucolytics and pharmacological approaches to the clearance of mucus, which is something that we all certainly should be interested in, and it's something that we all practice, most respiratory therapists. And by the way, most of our listeners are respiratory therapists. There are certainly some physicians and nurses and pharmacists, et cetera, out there that I always get nervous when I try to start listing off people on the team. But the people that have hands-on patients, me, you, nurses, out there that listen to this, but primarily respiratory therapists. And respiratory therapists, on occasion, don't necessarily agree with some of the approaches that that the rest of the team might have in taking care of patients. And some of that is personal bias. Some of it is this is the way we've always done it. Uh, horrible, horrible answer to any question. But I'd like to hear your thoughts on, as an example, every now and then, and I ask you this question a couple of times a year. I reach out, either call you or email you or get in touch with you in some way, or when I see you at a meeting. Um, but um, but every now and then somebody will order hypertonic saline for a patient. Who should get ordered hypertonic saline? Let's just talk about that for a minute.
Well, let's step back and say, what does that hypertonic saline or mannitol, which is approved in Australasia and in Europe, actually do? And it's a hyperosmolar agent. It brings fluid into the airway, um, but doesn't change the properties of mucus itself. When you think about it, if you have mucus that you've got a cold, you've coughed it up, it remains really cohesive even when exposed to water. If you happen to cough it into the sink, um, by secreting that additional fluid, the thought is it will unbind it from the airway surface. The term for that sort of drug is not a mucolytic, but an expectorant. And the other thing that hypertonic saline does really, really well is it induces a cough. And so for patients that have an effective cough, those who don't have stroke, neuromuscular disease, for those that have increased secretions that are binding to the epithelium, patients with cystic fibrosis, patients with um, uh, ciliary dyskinesia or bronchiectasis, they can benefit from hypertonic saline. Now, it's interesting that study was done a number of years ago in England at Imperial College and Royal Brompton that showed, when patients are with CF are both on hypertonic saline and Dornase, there is very little added benefit to the second one. Although I say most of the time it's still used. It's inexpensive, except for the fact that patients really don't like the taste and tend to want to drop it as the first medication that they don't want to inhale. It is effective. There are far fewer data, yeah, outside of the pediatric and the bronchiectasis literature, um, but again, it's widely used when we believe that there is an excess of secretions. One thing to recall is the patients with the most severe COPD, Gold 4, almost all have bronchiectasis as well. And so you may be treating that and inducing a cough that helps them to clear secretions.
So these patients, what about patients that have reactive airway disease?
Oh, well, it's great if you want to induce airway reactivity, hyperreactivity. The term reactive airways disease isn't used much for two reasons. First, there tends to be a focus then on airways response, hyperresponsiveness. It's a term from when albuterol first came into vogue, or salbutamol for your international listeners. Um, and asthma was all about airways hyperresponsiveness. We now think about asthma in terms of airway inflammation and again, mucus retention. But one of the ways to do a bronchoprovocation test is with a hyperosmolar secretion, a hyperosmolar solution. And so if you're administering this to somebody with known asthma, then you can very well run into trouble by increasing their airway hyperresponsiveness. So we tend to avoid this in most patients where we know there's significant hyperresponsiveness. In those where we don't know, we'll usually pre-treat our CF patients or our bronchiectasis patients with albuterol before administering the hypertonic solution.
So that's sort of what I was trying to elicit from you there was that this is that hypertonic saline probably shouldn't be given to somebody who is either actively bronchospastic or has the potential to become hyper responsive.
That was said
Or,
much more succinctly than I did. Thank you, Keith.
so anyway, so on our podcast here, we really like to we're all respiratory nerds at some level. But we really like to make things make sense for the bedside clinician, because I think those are the people that are really listening to our podcast for the most part. And so, if I wanted to really whittle away at this and really wanted to kind of boil it down to generalities, okay, because if I want to argue a clinical point with somebody who's trying to convince me to do something that I don't think is the right thing to do, then I can point to the literature, I can point to the science. But for most people, the average bedside clinician, how can I respond to somebody who wants to give a patient hypertonic saline, or even normal saline now is something that people are ordering quite frequently. I guess one day they couldn't get a hold of the hypertonic saline, so they just order regular saline and think that's a good idea also. But let's say I have a patient and they're ordering saline nebulizers because they have a mucus plug and they did a chest x-ray and they see that they have a right lower lobe density or something, and they just order Q4 saline treatments. How do I argue against that? And should I argue against that?
Well, you and I both know that not all lower lobe densities are mucus plugs. And the way to open up an atelectatic area is through the collateral channels more than actually moving these secretions. And it's only in opening up those airways that they'll be able to expectorate, to move that out. If they have a known reason for having retained secretions, whether it's hypersecretion or inflammation that you would see with bronchiectasis CF, COPD, particularly the more severe forms, and they are not prone to airways hyperresponsiveness, or you can mitigate that with albuterol, it would be worth giving it a short try to see if there's benefit, but you should see a response fairly quickly with hypertonic saline or with mannitol. I would remind them, though, that if the patient is prone to bronchospasm, both mannitol as Aerodol and hypertonic saline are used as bronchoprovocation and may be to the detriment of the patient. And some of these patients will have retained secretions because of weakness. And if they have a weak cough, giving the hypertonic saline isn't going to help a whole lot. I would like to segue to something that is similar but different, and that's when you're suctioning the airway and there's an artificial airway in place, such as a trach or an ET tube. It's very common to instill saline and then bag and then suction. But if you think about it, if instilling the saline is going to loosen the secretions, when you bag them, you're pushing them way down and making it much harder to clear. So I would say that would be an absolute no-no, um, but it's very commonly done. And I know that there was a segue from your question, but I think it's important to point out to our listeners.
A good point. I'd really like to move into to something to pivot to something completely different. You are also an expert in asthma, and I think that I'd like to touch base with you a little bit on some important points on severe asthma. Do we still call it status asthmaticus? Is that still an
Uh,
appropriate term?
a super question. You know, that term was first used a little over 100 years ago in the BMJ and went in and out of popularity. But during the 1960s and 70s, the term became used a lot more as failure to break an asthma attack with 3 shots of subcutaneous adrenaline, or epinephrine as it's called in the States. And it was adopted from status epilepticus, failure to break an epileptic seizure with 3 doses of your favorite anti-epileptic at the time. And it was widely adopted because it was sort of pseudo-Latin and it sounded very medical. And we like using confusing terms. Moving away, we really don't use the term. Well, we do use the term, but it's not tend to be accepted. We'll speak of acute severe asthma or life-threatening asthma. as a more appropriate term than status asthmaticus. Although for the most, again, if you're a purist, you don't use the term status asthmaticus, but everybody does know what it means, and that's not a hill to die on.
Right. So, so to kind of lead us into this conversation, I'll say that I got a call the other day. So, as you know, I do 3 12-hour clinical days a week as well. And I got a call to the emergency department and was told that we had a 20-year-old patient in status asthmaticus that was 31 weeks pregnant. And that made me a little nervous. I won't lie to you. I've been doing this for almost 30 years and still get a little unnerved by some things. And because I've seen asthmatics get really sick really fast and become very difficult to manage, I stopped by the ICU and I talked to the intensivist that was in the ICU. And I said, John, remind me of the things we can and cannot do to an asthmatic that's pregnant. And because I'm on my way down there. And by the way, I'd also like for you to head down there too as soon as you're done putting that central line in. But he said we can do just about it. You can give her all of the stuff, give her all of the beta agonists, give her the magnesium, do all of it. He said that there's nothing that you can't do to a person that's in status that's sick and has asthma that's also pregnant. Would you agree with that, first of all?
Absolutely. And a couple of points. At 30 weeks, the risk is more to a premature delivery than to the developing fetus. At 30 weeks, you're approaching maturity of a number of things, and most of these drugs don't cross the blood airway barrier well. I know you're giving some systemically, but the biggest harm to the fetus and to the pregnant mother is losing the pregnancy because of asthma. It's a hypoxemia. It's all of the things associated with gas trapping and putting pressure down into the abdomen. All of these things are far more dangerous to the fetus and to the mother than any of the medications we give. I will say you're liable to hear more of that with again, not trying to get too political. And if it sounds like that, sorry, not sorry. With the current administration, scaring people who are pregnant to avoid many medications that have been shown to be very beneficial, we may begin to see women who are stopping their medications out of fear or misinformation, and this can well provoke an asthma attack. So what you saw may be the tip of an iceberg that may be coming down the line.
Yeah, so it turns out that this particular patient, when I did go finally, or when I did get to see her, was not nearly as bad as advertised, and so she was fairly simple to take care of. All of that
Or
being said,
or the treatment they gave in the ED had already reversed much of it. We
yeah,
know
yeah,
how
yeah,
quickly severe asthma gets better if the patient hasn't been taking medicine.
right, yeah, and that was the case. The medics gave her some bronchodilators. The ER staff had already given her some bronchodilators. I gave her some when I got there, but then we sort of decelerated, and she was doing well. That being said, not all asthmatics turn around that fast, in my experience. And I always say when I teach this topic, I always call asthma a single organ failure. And I always say that, asthmatics, they seem to tolerate acidemia fairly well. And they also get better if we don't kill them with the ventilator. And so we go through a lot of we go through a lot of effort to not intubate an asthmatic. And so the medicines that we give them, the beta agonist, the magnesium, what else do we do initially to try to keep them from getting intubated?
Oh my gosh. Lots of things you give them. Often they'll be getting continuous nebulization, recognizing that within 10 hours you've completely saturated all of those receptors. You'll give them steroids which not only helps to reverse the inflammation, but also will increase the number of beta receptors in the airway and make them more responsive. We give them anticholinergics. There's really good evidence that anticholinergics have some effect on neutrophil dominant inflammation, which isn't touched by the steroid, but also serves as a secondary bronchodilator. Um, Magnesium has very little risk, very small benefit, so it's uniformly given. There is a tendency to give fluid boluses, and I'm not sure where that came from. My own personal preference is not to do that, given that there's significantly inflamed lungs. Giving a large amount of fluid can lead to some fluid leak within the airway. This was shown, gosh, a good number of years ago by Adam Warner. And so I would be a little bit more cautious with giving lots of fluids. We give them oxygen if they're hypoxemic. Um, and there's been a tendency to use high flow nasal cannula, but there are really no benefits to doing high flow over low flow. And the issues are not that it will hyperinflate the lungs, because very little of that flow goes down to the lower airways, but you're more likely to have the air go into the stomach, um, makes it more difficult for the patient to eat, potentially can uh, put gas into the bowel and compromise diaphragmatic function a bit more. So I'm a little bit cautious. Actually, I'll say I'm a lot cautious about the use of high flow. Um, and then certainly assess to be sure or to see if there isn't something else that is aggravating this. But the cornerstone of therapy is still your albuterol, your anticholinergic, and your steroid. Um, there's recently been some debate and again, I'm a pediatrician in the youngest infants with recurrent wheezing, whether giving a short course of azithromycin is beneficial because of its immunomodulatory effect. And this is a whole different discussion, an area of my interest. But a paper that just came out 2 weeks ago in New England Journal suggests that Wilden stated that that may not be the case. So it's been adopted and people may well be moving away from it. Um, Go ahead, Keith.
I was just going to say, something that just came to mind. Um, another reason why you may not want to just empirically knee jerk put somebody on high flow is because then people will tend to want to give the aerosolized medicine through the high flow. And our good friend Arzu we were on a few weeks ago,
I
and we were
saw
talking.
that. I
Yeah,
saw it. It was a great podcast, as she always does. I
yeah,
heard
she's
about it.
awesome.
Right. Yeah,
Yeah, but it doesn't work, right? It's not the best way to give an aerosolized medicine through a high flow, and sort of if the patient doesn't absolutely need high flow, and there are certainly patients that need to be on high flow, but if they don't need to be on high flow, then that's probably not the. If you can do it a different way, then certainly you should deliver the medicine a different way.
as you
Uh,
and I both know, there have been some really good studies run by RTs, put in the top literature, of stopping high flow. When it's
right.
been overly used, showing that there's no increase in core effects, but a significant improvement in length of stay and general outcomes. And it happens, you mentioned Arzu. Um, I have the privilege of this Wednesday speaking at the course she runs, the Jim Fink course on aerosol myths. So
Nice, that'll be good.
go straight into that. So yeah,
Maybe I
she's a
could have both of you on at the same time one day, and we'll talk about these things,
perhaps, although
perhaps.
she's far more knowledgeable than I.
She's a smart gal, no doubt about it. I love Arzu. She's a great friend. Um, so okay, so that's the medicine, that's the pharmacology aspect. Let's say we know that ketamine is good, right, for bronchospasm? Yes, no, maybe.
Yeah, ketamine does a lot of things, and I would tend not to use it for bronchospasm. There are a lot of things that have been shown to have mild effects, including hypercarbia, is a bronchodilator. I would stick to the knowns and the mainstay of therapy. there's always a tendency to start pulling out lots of other things. And it's hard at that time to know whether the thing that you added 5 minutes ago is making the difference where you're kicking in from the thing added 15 minutes ago. So I would be exceptionally cautious about putting in things where there are really limited evidence of efficacy and significant concerns about side effects.
Right. So maybe so let's transition real quick into okay, what we're doing is not working. And let's say we tried some non-invasive, which I think is a reasonable
Yes.
intermediary, and it's still not working. Now you're trying to give nebulizer treatments via the non-invasive because that's not something that you take on and off when somebody's an extremist. Let's say that's not working, and we need to intubate the patient, and maybe ketamine then would be a better drug to use than etomidate, for instance. I don't know. Um,
Potentially, I would say for sure that at that juncture, ketamine is probably safer than aminophylline and other things that we've pulled out in the past.
right. Well, that's a
That's
oldie.
another topic.
So they're intubated. Now there's things you got to look out for, right? You've intubated the patient because you thought that uh, at that point in time that you were going to delay definitive intervention, something that the patient really needed. However, it's also the one thing that potentially could make everything worse and make the patient much more unstable. So the way that the approach, I think, and of course I'm going to ask you to verify what I'm saying here is that once somebody's intubated, once somebody who's got severe bronchospasm is intubated, then your major concern is hemodynamic collapse from hyperinflation. Now this may be a time where you're more likely to give crystalloid volume than you would beforehand. But from a ventilator standpoint, low and slow, like low rate. Don't check. My first thing is when somebody comes to me and to help look at a patient that they've already gotten to this point with, is I say first stop doing blood gases. Stop doing it because you are going to want to react to that pH of 6.9 and that CO2 that's unreadable by your system, and you're gonna do dumb things. You're gonna turn rates up. You're gonna do things like that. So my first advice is to stop doing blood gases. And my second thing is turn the rate down as low as that ventilator will allow you to go. And and then start to monitor, use the graphics. The ventilators when I started training didn't even have screens. We couldn't see flow graphics. We couldn't see things that have become routine now. And um, you know, turn the rate down until you don't have significant air trapping, if you can get to that point, right? What else do you do with the ventilator to make sure that you don't hurt the asthmatic?
Keith, a number of years ago, Dwayne Williams and I wrote a book chapter um, for an asthma book that was mechanical ventilation of the asthmatic. And we basically said low and slow is important. Other things to consider are a longer exhalation time, if possible. It's paradoxical, but potentially a larger end expiratory pressure might help to recruit those that are de-recruited and actually reduce gas trapping. Um, but you really put your finger right on the important thing, the flow graphics. All of these things can be trialed with the flow graphics, and you should see a response fairly soon for some of these. Are you overpressurizing, and do you need to drop the PIP because you're getting that little peak at the end? Are you end up with a significant air leak that you can't manage? Um, as the physician at the bedside, I will sit there and, confession, make changes to the ventilator, watching the flow graphics, and then move everything back when I've decided what's best and let the therapist know. Uh, but it is absolutely the best way to try and determine what is working and what isn't working for your patients. Another point, though, there is a great paper that I think Kit Newth, well, from LA, was a primary author, where he looked at ICU asthmatics in pediatrics over a large number of different programs and what happened to them. And he found that, yes, a significant number developed air leak, but all of them developed air leak before intubation and ventilation. So although we're aware of this, we need to know that intubation and ventilation needs to be done gingerly, but it's not as bad as letting the patient get incredibly sick. The other thing that was shown in that paper is that there were national guidelines published on intubating and ventilating patients when the CO2 reached a certain point it was climbing. And invariably, these patients were intubated past that point. People waited. So I don't know if waiting too long is a good thing, if the guidelines are inappropriate, but at least people are being very cautious about intubating and perhaps doing it a bit late in some of these patients.
Yeah. I remember years ago where I trained and practiced for the first 14 years of my career. We bought an anesthesia machine for the department. We had an anesthesia staff come in and teach us how to use it and teach us how to use isoflurane. Fast forward to we only used it maybe twice a year, 3 times a year at the most while I was there for severe asthmatics. And then, of course, 10 years ago or so, um, VV ECMO got real easy to get a hold of. And I have seen patients go on VV ECMO with dual lumen cannulas in the neck without ever even getting intubated. And so that's a sort of an aggressive, probably not real common approach. But it avoids the positive pressure, right? You cannulate them, you do the ventilation with the machine, and avoid the positive pressure.
Although the positive pressure is probably scarier than it seems scarier than it actually is. I think because of the reports in the literature, although when looked at really prospectively, it's probably safer than we think. But I've got a bit of a story about the isoflurane if you're interested.
Sure.
So this work was done in the 70s by Carol Hirschman out in Seattle. She's an anesthetist who was very interested in asthma. And at the time, it was appropriate to use dogs as an animal model. We're not using them anymore, but she chose the Basenji Greyhound mix, and this is an interesting mix of dogs. It was used a lot for studying of airways, transplant, things like that. They weigh about 10 kilos. Like the Basenji lion hunting dog, they don't bark. They're non-barking dogs, I guess, but a large number of them spontaneously develop allergies and asthma. And this was a problem for her colleagues studying these for transplantation, wondered how to manage them. She thought it was a great opportunity to take these allergic asthmatic dogs. I guess since they didn't bark, they probably wheezed at you and see what worked. And as she put them to sleep to look at the airway, she found that isoflurane and inhalation anesthetics produce significant bronchodilation. Further study in her lab showed that the mechanism was almost entirely anticholinergic based. And so what we may be seeing is a concern about anticholinergics or not using them sufficiently in some patients um, in response to some of this. So I guess I know that's a segue, but I love interesting stories.
Yeah. Me too. But when you mention anticholinergics, should we be given? I hate to go backwards, but do it all the time. When we're first hitting this asthmatic in the emergency department, should we be giving continuous albuterol and Atrovent, or just albuterol?
I would give Atrovent, absolutely. Excellent work by Rick Hodder out of the Ottawa Civic and Susanna Shu out of Toronto show that adding an anticholinergic in the ED often will break asthmatics quicker, prevent admission. It certainly is additive for two reasons. First, because of the additive bronchodilation, but also because of its effect on neutrophil dominant inflammation. And we know the number one cause of an asthma exacerbation final cause in adults and children is a virus infection, often rhinovirus. In fact, human rhinovirus type C. Um, so yeah, there was we've gone back and forth about continuing them once they're admitted. They have very little downside. Anticholinergics, Heath, as you know, don't thicken secretions at all. They reduce the volume of secretions, so they're not mucospecifics like tetracycline that make mucus thicker. So my preference is to continue them as long as they're in the ICU. And we're using them as outpatients for severe asthmatics much more frequently. In fact, we will start an anticholinergic like tiotropium or glycopyrrolate for its effects on asthma before we'll consider using a biologic in our very severe asthmatics.
Wow. So just keep giving them that, giving them that adjuvant. So magnesium, albuterol, adjuvant, steroids, repeat. If they look like they're not getting better and they need some ventilatory support, gentle support with non-invasive. If you look like you're not getting better and you're really the team's concerned about the patient, you look at the risks and the benefits of being intubated and then make that decision. Once you're intubated, you gently ventilate them. You look out for air trapping. You manipulate the ventilator settings, use the lowest rate. Maybe not. You didn't comment on my comment about not doing blood gases. I suspect that you partially agree with that,
By
but
the time they're in the unit, they've got an art line in, and if you've got an art line in, you're going to get blood gases. So I think it's a moot question. I wouldn't jump to try and fix everything you see in the blood gas quickly, but you know they're going to have an art line if they're intubated and ventilated, and you know that people are going to be drawing blood gases. So the question isn't should you get them, it's what do you do with the results?
yeah, I worry about people people that may not be as um, I don't know what the word is, but
Pouring in bicarbonate to fix acidosis that doesn't need to be fixed.
yes,
Yeah, I agree.
that's a whole different episode.
Yeah.
So and then isoflurane. Haven't used it in many years. I think we're better at doing all the other things. Maybe that's why we don't use it as much. ECMO maybe. Again, that's a team decision, and what's the risk and the benefit of placing somebody. There's certainly risk on it. There's fewer risks now than there were 10 years ago, but there's certainly a risk in cannulating somebody and putting them on ECMO, and there's benefit. I wanted to ask you one more thing. I think about we were having a discussion about asthma in general. What are your thoughts on Heliox?
Um, that's another can of worms.
Yeah.
Heliox again is very low density, so it tends to get into areas where nitrous ox, normal oxygen and would not go. Heliox is expensive, which shouldn't be a reason for not using it, but it also changes everything on terms of flow because of the density. So whether you're delivering aerosols or ventilating somebody, that needs to be taken into account. Benefit is fairly limited for asthma, but if you are going to use it, once again, you use it when there's profound hypoxemia that you're not able to fix with hyperoxia. And, it comes down to the point, is it better to give 100% oxygen or is it better to give a mix of helium and oxygen with the thought that the oxygen you're giving will get in there? We tend not to use it for all of those reasons. If you do use it, it's again one of those things that you should see a benefit of fairly quickly. And don't you dare bring up nitric oxide.
You will not hear me talk about nitric oxide for anybody, um, for any patient population. But that's a good point. So I think maybe that's might be a good place to stop for right now. I appreciate you, Bruce, and look forward to seeing you in the future. Let me just go ahead and read what I got. My little my little closer here. Um, we'll go ahead and call that a wrap. Appreciate you, Dr. Rubin, for sharing your insight and expertise. Thanks to our listeners for joining, and please share our podcast. And of course, join us for next week's episode. What we like to do is every Friday we publish a teaser, and then that following Monday we publish the full episode. Don't forget to check out our website for other resources and opportunities at www.inspire-rt.com. Dr. Rubin, always a pleasure. And you're headed on a trip soon.
I've got a bunch coming up. I've got to
Yeah.
be in Iceland next week for a PhD, and then the week after we have our International Pediatric Pulmonary meeting in Bologna, where I'm on the board. And then a couple weeks after that, I'm in Guatemala since I'm on the board of the Children's Hospital there, and they're having their national meeting. And they'll be going to El Salvador as well while I'm there to speak. So it's a busy few weeks, but I'm not off to Ukraine again until September.
Well, thanks for all you do, sir. We really appreciate your volunteerism and your being such a humanitarian. And we appreciate it. Thank you so much.